Welcome to this anaphylaxis training course in a series of webinars organized by OmniCuris. My name is Antonella Muraro, heading the Food Allergy Referral Center at the Padua University Hospital. Anaphylaxis has been my research field for the last 10 years, and I've been the chair of the European Academy Allergy and Clinical Immunology guidelines published in 2012 and updated in 2021. The webinars plan is organized in 4 modules where we have tried to tackle the most cutting-edge areas for anaphylaxis. First of all, vaccination and anaphylaxis, understanding the definition of anaphylaxis and the risk, and why adrenaline is important as first-line treatment. And then how to manage properly anaphylaxis in the community and what are the situations at risk for anaphylaxis, focusing on critical environments. The main aim of these webinars is to recognize adequately anaphylaxis and understanding the risk in all settings, as well as promoting increasingly efficient and patient-centered care in order that the patient get the treatment they need, how and when they need it. The first module is devoted to the role of anaphylaxis in vaccination. And I will introduce the main speaker with a short overview on how are the anaphylaxis symptoms and the clinical operational criteria, as well as on what we mean for adverse reactions to vaccines. It's difficult to recognize anaphylaxis symptoms as at the very beginning they may be vague and overlap with other diseases. The initial usual symptoms are pruritus at the scalp, palm of hands, and soles of the feet. And in the infant is even more difficult as the child can develop sudden irritability. It can stop playing, have an inconsolable crying, becomes pale and somnolent, and start vomiting. So the constellation of symptoms range from cutaneous mucosal, respiratory symptom with bronchospasm, wheezing, and severe asthma, involvement of cardiovascular system with collapse and sudden drop in the blood pressure, gastrointestinal with cramps at abdomen, and neurological impending doom due mainly to the drop in the blood pressure, such as dizziness. So in order to be able to catch more than 95% of cases in a busy emergency department in 2006, the NIH at the NID together with a patient organization called FAN, have developed a clinical operational criteria which have been recently reviewed by the European Academy Anaphylaxis guideline in a systematic review published in Allergy 2020. And in this guideline, we have evaluated more than 50 studies involving diagnosis, managing, and preventing anaphylaxis. However, focusing on diagnosis, we have seen that the NID FAN criteria are the most accountable. And these are a set of 3 criteria which are ranging from respiratory, cardiovascular, and skin and gastrointestinal system in a very structured way. So the definition of anaphylaxis is stated as a generalized allergic reaction, sudden onset, and that may progress to death. But look now at the first criteria. Anaphylaxis is likely when any one of the 3 following sets of criteria are fulfilled. So skin mucosal tissue involvement combined with the airway compromise or combined with reduced blood pressure or associated symptoms, as well as airway compromise with reduced blood pressure. Sometimes skin mucosal tissue are not involved. So this is the main set of symptoms which usually are present in a patient going admitted to the emergency department. But in order to catch more subtle symptoms, the researchers have developed a second criteria, which is including the clinical history of the patient, such as exposure to a likely allergen for that patient. So skin mucosal tissue involvement together with airway compromise, which can start as mild symptoms, can be alerted when we have a rapidly exposure to a likely allergen, as well as persistent GI symptoms. The third criteria is trying to catch the 10% of the patients who don't develop any breathing symptom or skin symptoms, but the only presenting symptom is a sudden drop in the blood pressure after exposure to a known allergen for that patient. So again, introducing the clinical history of the patient in order to be able to catch that minority of patients who may be very severe. And this is the infographic. Why anaphylaxis has become so popular for vaccination? With the COVID pandemic and development of new vaccine, we have seen that allergic reaction develop, including anaphylaxis, develop after receipt of the first dose of the Pfizer-BioNTech COVID vaccine, alarming people. So there was the need of reviewing accurately the options of the adverse reactions to vaccine. Adverse reaction after vaccination can be very different. So we have listed here the cause-specific type of these adverse events after vaccination. Vaccine product-related reaction, and in this case, the adverse reaction is caused or precipitated by a vaccine due to the inherent properties of the vaccine product. Vaccine quality defect related reaction caused or precipitated by a vaccine, which is more related to quality defects of the vaccine product, including the devices provided by the manufacturer. Immunization error-related reaction caused by inappropriate vaccine handling, administration, and this is by its nature preventable. Immunization anxiety-related reaction we will see later on as well, and this is arising from anxiety about the immunization. Coincidental event. Sometimes this reaction is caused by something other than the vaccine product, immunization error or immunization anxiety. The adverse reaction to vaccine can be evaluated as local, which can be mild, pain, swelling, redness, mainly in the area of administration, or large local reaction within 72 hours, related mainly to hypersensitive type 3 or 4 of allergic reaction. And these may evolve or not evolve in a systemic reaction, which can stand alone by itself, again, which can be non-allergic or allergic, and non-allergic as fever, non-specific systemic symptoms such as rash, irritability, malaise, diarrhea, headache, muscles pain, syncope, and allergic, immediate anaphylaxis or delayed. We spoke before about anxiety related to immunization, and this is the difference between anaphylaxis versus vasovagal reaction. And we can see that we can evaluate several areas in order to understand exactly which type of reaction we are facing. Onset from time of immunization, which doesn't help too much. In anaphylactic reaction, it develops a few minutes delay, typically within 30 minutes, but as well it is during or shortly after the administration for the vasovagal. Respiratory can be different. We have for anaphylactic reaction, wheezing a stridor. The breathing is normal. We have hyperventilation in a vasovagal reaction. We can have involvement of a cardiovascular system with tachycardia, hypotension in anaphylactic reaction, self-limited bradycardia, and hypotension for vasovagal. The skin is much different. Flushing, itchy rash, angioedema, urticaria for anaphylaxis, pale, sweaty, cold, clammy for vasovagal. Gastrointestinal, we have abdominal cramps for anaphylactic reaction, nausea and vomiting for vasovagal. And for neurological system, we have loss of altered consciousness with little response to prone positioning, which is exactly the opposite for vasovagal reaction with good response to prone positioning and self-limited loss of consciousness. Vaccine anaphylaxis overall is rare. Local reactions are more common. And if we see the rate for million doses for each vaccine, overall, for all vaccines, we have a rate of 1.31 for million of doses, in total 25.17 total doses administered in millions. And we now would like to go in depth in the managing the risk of anaphylaxis from vaccination, addressing three most important questions. Before vaccination, who is at risk, who is not at risk? During vaccination, how to manage anaphylaxis? And after vaccination, what should I do if people react to the first dose? And I am pleased to introduce to you the expert in vaccination and anaphylaxis who will help us to better understand the topic, and who is Professor Line Heise Garvey from Denmark. Welcome, Line.
My name is Line Heise Garvey. I'm a consultant and associate professor at the Allergy Clinic Gentofte Hospital in Copenhagen, University of Denmark. And I've got the pleasure today of speaking to you about vaccination and anaphylaxis. I am actually a specialist in anesthesiology, and I've subspecialized in allergology. I'm the co-founder and chief physician of the Danish Anesthesiology Center, where we investigate patients with perioperative allergic reactions. I'm also an associate professor at the University of Copenhagen, and as I said, a consultant at the Allergy Clinic in Gentofte Hospital. I'm the vice chair of the Danish Society of Allergy. I'm a board member of the EACI Drug Allergy Interest Group, and I'm an active member of several task forces in the EACI. And my research interests include the diagnosis, treatment, and mechanisms of anaphylaxis, and all aspects of drug allergy, including allergy to vaccines and rare allergens such as polyethylene glycol, which I'll come back to later. So what I'll be covering in this talk is the prevalence and causes of anaphylaxis to vaccines, a bit about the acute management of anaphylaxis to vaccines, epidemiology of reactions to COVID-19 vaccines, and testing, how to test for vaccines and excipients. And I hope I'll be giving you an update on the prevalence and causes of anaphylaxis to vaccines, and that you'll get an insight into how to manage these reactions and investigate them subsequently. So when we're talking immediate hypersensitivity to vaccines, these are very, very rare reactions. The problem is the lack of knowledge about these reactions. So when they do occur, when the reactions that are perceived to be anaphylaxis occur, it induces fear in the patients and in the healthcare workers, and it'll lead to various problems. So for the patient itself, it might be that they are actually not given necessary vaccinations because the doctors are worried or because the patients themselves are worried. They may be worried about other vaccines or other drugs and actually not be given useful drugs in the future. And then there is with the vaccine or vaccines also this fear of vaccines in the community. So if there have been reactions that are publicized, then people the word will spread that this may be dangerous, and people will perhaps stop having the vaccines or be worried about having the vaccines. And this can lead to suboptimal herd immunity. And we've seen this in some countries with COVID-19 vaccine, that this is quite unhelpful really to the vaccination effort. But if we look at what is the risk of anaphylaxis after vaccination, and this is something that really the COVID-19 pandemic brought on, and the vaccinations, because before that, really not many people were interested in it because it's so rare. But this study by McNeil, published in JACI in 2016, they looked at 25 million vaccine doses administered. They found just over 1,000 potential cases of anaphylaxis, and only 33 of those actually fulfilled the criteria for anaphylaxis to the vaccine. Of those, 60% were women. The median age was 17, and this is because obviously a lot of children also have vaccinations, but as you can see, it's mainly adults who have reactions. There were no deaths, and there was only one patient hospitalized. So those who did get anaphylaxis were managed in the right way. So this study shows calculated an overall rate of anaphylaxis to vaccines, and that's overall all vaccines of 1.3 reactions of anaphylaxis per million vaccine doses, which is said to be very rare. So when we look at systemic immediate type reactions, so reactions that occur within minutes to hours after exposure and including anaphylaxis, there was a paper, an EACI position paper on the practical aspects of vaccination and allergy, published in 2017. And here they looked a bit closer at the data from the McNeil study I just showed. And as you can see at the bottom line, all the vaccines, so the incidence of reactions to all vaccines was 1 in 3 per million, and a few of the vaccines has slightly higher rates, but still 5 out of 1 million doses has to be said to be rare. So the conclusions from this position paper was that allergic reactions to vaccines are rare, and in fact they're mostly directed to the additives, and I'll come back to that. So knowledge of the ingredients is of importance when you vaccinate allergic individuals. There are also localized reactions, and they're actually a lot more common. So pain and redness and swelling at the injection site, which is usually self-limiting and usually does not always recur on subsequent vaccination. As you can see, incidences of those much more common, 1 in 3, 1 in 2, 1 in 20 with the various vaccines. And these type of reactions obviously do not contraindicate subsequent vaccinations. Neither does aluminium reactions. So a lot of vaccines contain aluminium as an adjuvant, and aluminium can cause contact allergy or type 4 hypersensitivity, which gives localized nodules at the injection site. And these may recur at subsequent vaccination if there is aluminium in the vaccine. If these patients are managed with a deep intramuscular injection of the subsequent vaccination, symptoms tend to be less. But again, in the EACI position paper on vaccination allergy, the conclusion was that aluminium allergic patients can be vaccinated with aluminium-containing vaccines without inducing severe reactions, but they may just get recurrence of these itching nodules. But this obviously has to be weighed up against the benefit of having the vaccines, which usually outweigh this type of side effect. So the EACI position paper concluded that the various ingredients of the vaccine not related to the actual vaccine are typically the ones who could be allergenic. And they include things like preservatives to avoid contamination, like thimerosal, adjuvants like aluminium salts that help stimulate a stronger immune response, stabilizers which keep the vaccines potent during storage, such as sugars and gelatins. And those are things that are actually added to the vaccines, but there are also things that were used in the production of the vaccines and are actually actively removed. But you can never be absolutely sure that there aren't trace amounts of these in the vaccines. They include cell culture materials used to grow the vaccine antigens, for instance, egg protein and various culture media, inactivating ingredients that are used to kill viruses and inactivate toxins, for instance, formaldehyde, and then antibiotics, again used to prevent contamination by bacteria, for instance, neomycin. So it's thought that some of these can potentially cause allergic reactions to vaccines. But I think the one that everyone knows about is egg protein, because there are a lot of egg allergic children, and egg protein is possibly present in trace amounts in the influenza vaccine, but also in yellow fever vaccine, TB vaccine, and measles and rubella vaccines. The influenza debate has been going for a long time, and recently the Americans updated their practice parameter about vaccination and allergy, and they looked into the influenza vaccines in egg allergic patients problem, and they published this in 2018. And in fact, from a big literature review, what they could conclude was that for patients with egg allergy, influenza vaccines are generally safe. And what the statements they made were that influenza vaccines should be administered to individuals with egg allergy of any severity. No special recommendations, no special precautions are recommended other than those that are normal for any vaccine. And the use of non-egg-based vaccines is okay, but it's not medically necessary or preferred to using the ones that where manufacturing was based on egg. And live attenuated influenza vaccine may also be administered in patients with egg allergy of any severity. So I think that the discussion about influenza vaccines is that really they can be administered to any patient with egg allergy. There are other reported allergens in relation to vaccines, again, basically additives or derivatives. And this is also from the EAACI precision paper. And basically they did a literature review, and many of these are based on very few case reports. But casein and cow's milk protein can be present in trace amounts in some vaccines. Gelatin is present in the measles and rubella vaccine, varicella zoster vaccine, TBE, and it has been actually recently replaced with human albumin, because after alpha-gal became a problem and patients reacting to gelatin, there are reports of people with alpha-gal allergy reacting to gelatin-containing vaccines. Then there are some of the adjuvants, and polysorbate 80 is the one that has gained some press over the last year and a bit because of the potential cross-reactivity with polyethylene glycol. We have to remember, though, then before we had the COVID vaccines, where some of them contain polysorbate 80, there were no reports. I think there's one report on a patient reacting to polysorbate 80, potentially from a vaccine. And it's used very widely in a lot of vaccines and has been for years and years. So polysorbate 80, probably not a big problem. And then there are the antibiotics. Again, in trace amounts, they're present in, for instance, the polio vaccine, and this could cause trouble for some patients. And then some things that are maybe a little bit different is the fact that sometimes vaccines are in glasses with latex stoppers, and you can, if you draw up through a latex stopper, you might actually inject a little bit of latex into a patient, which could be a problem with latex allergy. And there are also yeasts in some vaccines, such as the hepatitis B vaccine. But as I said, relatively few cases reported on each of these. So when you have a patient where you suspect that they're having anaphylaxis after you've just vaccinated them, what do you do? Well, you do what you do in any other case of anaphylaxis. You treat the patient. And these are the recent guidelines from the EAACI again from 2021. And basically, you assess the patient, airway, breathing, circulation. Are there life-threatening A, B, or C problems? So an upper airway life-threatening problem with dysphagia, hoarseness, stridor. Is there a lower airway breathing problem, a B problem that's life-threatening with severe bronchospasm, breathing difficulties? Is there a circulatory problem with tachycardia, hypotension, dizziness, fainting, confusion? Then often with skin symptoms, then you should treat the patient for anaphylaxis with intramuscular adrenaline, 0.3 milligrams intramuscular in adults, and 0.15 milligrams intramuscular in children below 25 to 30 kilos. And then you have to position the patient correctly. So you have to, if there's circulatory problems, lie the patient flat, elevate the legs. And if they also have a respiratory problem, sit them up with elevated legs. So these are the things you can do in any setting. Obviously, in a hospital setting, fluids, treating the bronchospasm, repeating the adrenaline, calling for further help and all that sort of thing, the advanced anaphylaxis treatment. But in fact, a lot of vaccinations are happening outside the hospital setting. So really, it's this first part of the algorithm that's the most important. Give the adrenaline, that's what's going to save their life. And then call the emergency services and get them to take the patient to a hospital. So when you've had a patient with suspected anaphylaxis or immediate type reactions to vaccine, like any other case of anaphylaxis, take a detailed history. What were the symptoms? What was the timing? What treatment did they have? Was it enough with an antihistamine, or did they have repeated doses of adrenaline? How long did it take for the case to resolve, the symptoms to resolve? Were there any other potential allergens? Had they just taken an ibuprofen for a headache? Did they have just eaten something they're potentially allergic to? And are there any previous reactions of allergic reactions in the history? And what drugs are they taking normally? And then, very importantly, you have to take a tryptase when you investigate the patient, but you also have to rely on someone in the emergency department having taken a tryptase at the time of reaction. So to assess tryptase properly, you have to have a sample that's taken around an hour after the reaction, and you can then take a baseline that you can use for comparison. I'll get back to that. Skin testing with a suspected culprit vaccine and excipient. I'll come back to how to do that, but primarily skin prick test for the immediate type reactions and patch tests for delayed type reactions, and then provocation. And for vaccination, provocation is typically revaccination when you need the next dose. This was a big issue in the COVID-19 pandemic because we needed more than one dose. So this is, in fact, the provocation is really a revaccination with the suspected culprit vaccine. And whether you go on to provocation or not is obviously dependent on the indication for the vaccine. Provocation can be obviously done subcutaneous, intramuscular, depending on the vaccine. And you can either do a full dose or a divided dose, depending on the risk to the patient. And many different recommendations were made, certainly in the COVID pandemic. But if we go back to tryptase in anaphylaxis is very important because it's a helpful marker of mast cell degranulation and sort of a relatively good marker of an IgE-mediated reaction. And those are the ones we want to catch. Those are the ones with the highest risk of subsequent reaction on subsequent exposure. And as you can see, on the graph here, the tryptase levels peak at around an hour after the insult or the anaphylaxis symptom onset, and the values of tryptase can be elevated for a number of hours depending on how high the initial value was. But the recommendation at the present time is to measure the tryptase at 30 minutes to 2 hours after symptom onset, because you hopefully catch the peak there, and then you have to measure the baseline at least 24 hours later. And the recent recommendations are that significant elevation of tryptase is present if the reaction tryptase is greater than the baseline tryptase times 1.2 plus 2. So quite discrete elevations can be relevant, and we do no longer use an absolute cutoff. Earlier, it was said that if the value was below 11.4, then it wasn't elevated. But you can actually, with this algorithm, easily have elevations within that interval. So it is very important to use this more sensitive algorithm. It's been published recently in many guidelines, and this is just one example from JACI in Practice 2021, Bitte et al., a large review article. So remember the tryptase, and hope we have to make sure that our colleagues in the emergency departments know about tryptase and take it. Skin testing. Again, this doesn't actually differ much from skin testing you would use in any other allergy setting. The skin prick test, as we know, is less sensitive than the intradermal test, but it has a higher specificity. So when you have a positive, you can be relatively sure that it's a true positive. And there's a very low risk of systemic reactions or anaphylaxis with prick test. Intradermal test, on the other hand, higher risk of false positive results, but it's also more sensitive than the skin prick test. So there can be situations where you have a negative skin prick and you would carry on with an intradermal test. However, intradermal tests also carry a risk of systemic reactions. And for vaccinations, really, the recommendations, there are many different recommendations, many different studies out there. But what certainly my conclusion on what's out there at the moment is that for vaccinations in immediate type allergy, really skin prick test with the vaccine and potentially some of the excipients is the way forward. And in delayed hypersensitivity, the patch test should be used, because for some of these vaccines, intradermal tests carry a high risk of false positive testing, both on immediate and on delayed testing. And we really don't have enough experience, certainly not with the COVID vaccine, to use this as a tool, because we end up preventing potentially some patients from having the vaccines who should have just had it. So skin prick test and patch test is, in my view, the best tests for vaccine allergy. But when we have these patients who are referred with allergic reactions to vaccines, what should we be thinking of other causes? And really, based on our experience with drug provocation for years and years, and with a number of patients coming in with suspected reactions to the COVID vaccine, I just want to run through a few symptoms that we see in vaccinations in our allergy clinic. So some people develop flushing, generally often women, and actually the flushing, it can be quite marked. It's on the neck, face and chest. But interestingly, this often usually only occurs in people who will admit to flushing when they're stressed. And in fact, we've seen examples of patients who flushed before they even had the vaccine. Tingling in the mouth and lips, a typical sign of hyperventilation, and patients need reassurance that this is not a dangerous sign. The same, in fact, with subjective lump in the throat or difficulty swallowing as the only symptom. If you have an ENT doctor who can look into the patient's throat, you will see that there's absolutely nothing there. But often you don't have that, and you will have to go on the symptoms and reassure the patient. Often the symptoms will disappear in a glass of cold water and reassurance. And then, of course, there's vasovagal reactions with dizziness, feeling clammy, drop in pulse and blood pressure. So drop in pulse and blood pressure. Whereas anaphylaxis obviously is an increase in pulse and decrease in blood pressure. So vasovagal reactions are actually quite different, but in the clinical setting can be a little bit difficult to differentiate. And these reactions actually have a name. They're called immunization stress-related response. And I didn't realize this until about a month ago, when I came across this report produced by the World Health Organization in 2019, huge report about immunization stress-related responses in patients who are having vaccinations. And they're both addressing individual reactions and also sort of reactions on the level of society, where sort of mass hysteria sometimes makes the vaccination effort challenged because of people thinking they're having reactions. They're reporting it to the social media or other things, and other people will then not have the vaccination. So it's a very interesting report. And one of the things they are talking about is how to manage the acute stress response. Because what you want to make sure that the patient realizes that this is not allergy. Because some people will go away and think they've had an allergic reaction. And the most important thing is to maintain a calm and reassuring atmosphere, to be positive and professional. And then quite quickly differentiate the symptoms from anaphylaxis and make the diagnosis. And obviously, if it's vasovagal reaction, stop the reaction, lie the patient down, talk to them, ask them to practice muscle tension, so move their muscles to get the circulation going. And in cases where people are actually fainting, sternum massage, so just inducing a little bit of pain on the sternum will wake them up and get the pulse up, which can stop the reaction. But once you've managed the reaction, it's very, very important to clearly explain that these are benign and self-limiting symptoms. It's got nothing to do with allergy, and it's not related to the vaccine. Because if you don't get that message across, they may not want further vaccinations. It's also important to play it down. So avoid starting giving all medications, avoid getting ambulances and sending them to hospital. Because if they've been to hospital with a vasovagal reaction, they will think it's anaphylaxis, and the people receiving them will think it's anaphylaxis, and it's much, much, much more difficult to persuade them that it wasn't. And in fact, we saw this with patients who were, or healthcare personnel at the very start of the vaccination effort, who had relatively minor symptoms out in the nursing home where they worked, and they ended up with adrenaline and going into the hospital and the label of anaphylaxis, where in fact they had no skin symptoms, they had no tryptase increase, and probably what's happened is that some of these symptoms had escalated. So all this about the immunization stress-related response was something that became very apparent to all of us in the COVID vaccination effort, COVID-19 vaccination effort. As you all know, the first doses of the Pfizer COVID vaccine was given in the UK on the 8th of December 2020, and the next day there were reports of 3 immediate type allergic reactions to the Pfizer vaccine. And that sends sort of shockwaves through the allergic community or the allergy community because what we all realized was that these messenger RNA vaccines contained polyethylene glycol. And some of us who'd had experience with patients allergic to polyethylene glycol got a little bit worried because we knew that the risk of anaphylaxis from other vaccine was very low. And suddenly we had 3 cases in one day to a vaccine that contained polyethylene glycol 2000, as do both the Pfizer and Moderna vaccines. No other vaccines had ever had polyethylene glycol as an ingredient, and here was a vaccine that was going to be spread across the world in 2 doses. And so very quickly, the messenger RNA vaccines became contraindicated in patients with confirmed allergy to PEG. And so this also was an issue when the vaccine was being approved across the world, and all across the world. Basically, people who had had severe reactions to the first dose of the vaccine, or people who had had a severe allergic reaction to any ingredient of the vaccine, could not get the Pfizer COVID-19 vaccine, or Moderna for that sake, the messenger RNA vaccines. And the focus again was on polyethylene glycol, PEG 2000, which was in the vaccines, and then also on polysorbate 80, because patients with allergy to polyethylene glycol sometimes also test positive for polysorbate 80. I had actually been interested in allergy to polyethylene glycol since 2010 when I saw my first patient, and we had developed in our clinic, in fact, a very, very standard setup for testing with polyethylene glycol. At the time the COVID pandemic vaccination effort started, we had 13 patients with PEG allergy. I had a student who in 2015 did a review on PEG allergy, and as you can see, it was very rare because he could only identify 35 cases across the world in the period from 1977 to 2015. These were all adults, and there were primarily reactions in men. But what was striking about this allergy was that reactions were often severe, and in fact, 26 of the 35 cases, so 3/4 of the patients had had anaphylaxis on exposure to PEG. And all reactions were very rapid in onset. So within 10 minutes of exposure to the drug that contained PEG, they would have localized itching and sometimes progression to anaphylaxis, severe anaphylaxis. So, and the causes were mainly laxatives or bowel prep and all, but there were also other causes, tablets and depot steroids. And this is interesting, this review has been very cited since the COVID vaccination effort started. The other thing that she found in this review was that there are some polymers that are similar and share epitopes with polyethylene glycol, and that is poloxamer and polysorbate 80, and there were reported single cases of possible cross-reactivity to these polymers. What she also showed in a different article was that macrogol is everywhere. This is from the healthcare setting, and it is found in tablets, dressings, disinfectants, lubricants, gels, hemostatics, anesthetic sprays, all sorts of things. And in fact, in the home, it's found in a lot of things as well. So it's very, very widespread. And here was an ingredient that is found everywhere, and it's actually in 30% of tablets. It's in most cosmetics, creams, shower gels, that sort of thing. And now also polyethylene glycol 2000 was an ingredient in the Pfizer and the Moderna messenger RNA vaccines. And in fact, the other vaccines, so the AstraZeneca vaccine, the Johnson & Johnson vaccine, and the Novavax vaccine all contain polysorbate 80 with this potential for cross-sensitization, and the Sanofi Pasteur vaccine contains polysorbate 20. So these were the vaccines that were talked about initially, and this made it a little bit difficult for patients with allergy to polyethylene glycol to have a COVID-19 vaccine. And so because it was contraindicated in patients with reactions to the excipients, testing for the excipients was done all over the world. And there was a great variation in the test protocols that people developed. subject to the experience, which was often limited because this is a very rare allergen, and also subject to the availability of the vaccines. So initially, testing with the vaccine was not an option because they were in short supply and it was important to get patients vaccinated. So in some countries, vaccination or testing for excipients was done also because of lack of availability of the pure products. Drugs containing polyethylene glycol or polysorbate 80 were used for testing. So you didn't in the States, for instance, it's not the pure product that's tested, whereas in Europe, excipients or the polyethylene glycols are available in the pure form. And as you can see from this recently published EAACI position paper on allergies and COVID-19 vaccines, we did a survey of 42 centers in Europe, and you can see there's a great variability in which PEGs were actually tested, because there were no guidelines on how to do this. And people were using skin prick tests, some were using intradermal tests, again, no real guidelines on how to do it. And so when you start testing with some, basically a population where you don't really know what the risk is, and with some excipients you don't have a lot of experience with, there is a risk of false positive testing and false negative testing even. So what you really have to do is you have to think, well, is it really feasible to test all patients that have a suspicion of a COVID-19 vaccine reaction with the excipients? What is the pre-test probability that they have a reaction to the excipients? It's obviously better to direct testing at those who have a high pre-test probability of allergy. So in patients, for instance, with a history that's suggestive of PEG allergy, which is an IgE-mediated allergy, those have a high pre-test probability, and it makes sense to do testing for excipients in those patients. But what about the patients who have all sorts of COVID-19 vaccine reactions, some of them probably not even allergic? Is it actually feasible to test all of these patients for excipients? And then patients who come and were worried that they might react to the COVID-19 vaccines because they have all other allergies, the pretest probability in that population is very low, and probably they shouldn't be tested. And so the tests that are used, it's also important that you are using a confirmed non-irritant test. There was an example in the US of using some eye drops containing polysorbate 80, and it turned out that a lot of healthy volunteers also tested positive on these eye drops, and they were stopped being used as a marker for excipient allergy. So really, you need to know what you're doing. You need to know who you're testing and what you're testing with. And generally, obviously, mainly you want to test for diagnostic reasons to either prove or disprove an allergy. But for some patients that we had referred, it was also to reassure them and show them you can tolerate this vaccine. We don't think there's a risk, but you obviously do. So we're going to have to vaccinate you to show you that you tolerate this vaccine. And this comes back to, again, the immunization stress-related responses, which did actually play a big part in reactions to COVID-19 vaccines. So in our allergy clinic in Gentofte Hospital in 2021, we had 1,100 patients referred with potential worry about allergy to the vaccine. Many of them could be rejected on referral, but there are some who'd had reactions on the first dose, and we revaccinated a number of those, and we've done over 100 revaccinations of patients in our allergy clinic with immediate type reactions. And a number of them, I think it's about 15 of them, had diagnosis of anaphylaxis at the place they were vaccinated, but none of those actually had an increase in tryptase, and most of them didn't have any real skin symptoms. So we've revaccinated all of those we had referred, and none of them had anaphylaxis after vaccination. A few of them had some milder symptoms than on the first dose, usually something that could be treated with a single dose of antihistamine. And we didn't identify any patients who had a PEG allergy and had a reaction to the messenger RNA vaccine. And in fact, quite early on, we published this paper together with our American colleagues to show that even if patients are referred with anaphylaxis, please be aware that often they didn't really have anaphylaxis, and it was important to get patients vaccinated. So we did actually vaccinate patients with anaphylaxis to the first dose successfully in our center. So this whole population of patients with potential allergy to the vaccine probably have a very low pretest probability of allergy to either the vaccine or to the excipient. So who is it who have a high pretest probability of allergy to the excipients? Well, because we have worked with allergy to polyethylene glycol in our department, in fact, we now have 22 patients with allergy to polyethylene glycol. We have a lot of experience, and we published this recently about optimizing investigation of suspected allergy to polyethylene glycols. And the investigation algorithm here can also be used for patients where you suspect allergy to PEG in vaccination patients. But patients who have a high pretest probability of a reaction to PEG generally have had severe allergic reactions, often to two or more structurally different drugs. They also can have reactions to the tablet form of penicillin, for instance, but not the IV form. They can have a severe reaction to the active to a drug where the active ingredient has been included. So somebody excluded someone who reacts to a tablet paracetamol, but they tolerate the IV paracetamol. And so also drugs that are containing PEG or PEG derivatives, people with repeated reactions to those and who haven't tolerated other drugs with PEG. And then also severe unexplained perioperative reactions. So there are some patients who have a high pretest probability, and here excipient testing is reasonable. This is the paper we published recently and the investigation algorithm, and the materials, supplementary materials to this article show how to where to get the products and how to dilute them. But what we do is we do only skin prick testing, never intradermal testing with PEG or PEG derivatives. We've never needed to do intradermal testing. We've always been able to prove or disprove an allergy on skin prick testing. We do a stepwise approach where we use increasing doses of PEG up to PEG 6000. We also test with poloxamir 407 and polysorbate 80, as those are the excipients, the polymers that look like PEG. And if these are negative, we will move on and use a higher molecular weight PEG, again in stepwise increasing concentrations. And what we sometimes see is that they might test negative on PEG 6000, but when we come up to PEG 20,000, we see positive tests on those. And we obviously have lots of negative controls on these concentrations. If all of this is tested negative, we repeat it 4 to 6 weeks later, and if that also tests negative, it's very unlikely that they have PEG allergy. But if you still suspected, that's when greater challenge might be indicated, or perhaps intradermal testing. We've never had to do this. We have been able to make the diagnosis on the prick test. You may have patients who think they're allergic to excipients and drugs, and this excipient series can also be quite helpful. And they obviously have a low pretest probability, and there we're not careful. We just put all the prick tests at once. But this is an example of how we do it. So these are the increasing molecular weights of macrogol. And what we found is that if you test positive to macrogol 6000, you will test positive to 20,000. So there's no need to do that. But what we also see is that even if patients have clinical reactions on macrogol 3000, they may still test negative on prick test with macrogol 3000 and then positive on a higher molecular weight. So you cannot rule out allergy to macrogol by just testing with the low molecular weights, basically. And that's an important take-home message. Another important take-home message is that I've told you earlier that skin prick testing carries a very low risk of systemic reactions. Well, that is different for PEG. So with prick testing with PEG, if you do it in a patient with a high pretest probability and a high risk of allergy to PEG, there's also a risk of systemic reactions on prick testing. And this is a patient who had a reaction to a depomedrol injection, negative prick test for macrogol 300 and 2000, but clearly positive to macrogol or PEG at 3000 at the top of the arm, number 3. We also tested for the poloxamir and polysorbate 80. And actually, after these 3 tests had tested positive, he developed wheals on the trunk, so systemic urticaria. And this is the important take-home message is when you've got a positive test, there's no need to go any higher. If we'd done a prick test with macrogol 6000 in this patient, it would have been very, very, very clearly positive and potentially induced a more serious systemic reaction. Lastly, all these PEG allergic patients, we have there was this worry initially that polysorbate 80 could also be a problem, but there was also pressure to have these patients vaccinated. And in fact, we offered 7 of our patients vaccination with the Janssen vaccine, and we've published that they tolerated that nicely. And we got together with our American colleagues who had 3 patients. So we had a total of 10 patients who tolerated the polysorbate containing Janssen or Johnson & Johnson vaccine without any reaction at all. So there is hope for the PEG allergic patients. And in fact, there are also now 1 or 2 publications suggesting that maybe they may also tolerate the Pfizer or Moderna messenger RNA vaccines. So in conclusion, on vaccination and anaphylaxis to vaccines do occur, but they are very rare. But vaccines should be performed somewhere where anaphylaxis can be recognized and treated. There should always be the availability of giving adrenaline and an algorithm for how to call the emergency services if you're not in a hospital setting. Revaccinations of patients with the first dose reactions, including anaphylaxis to the COVID vaccines, have been generally successful. And this actually goes for most of the other vaccine reactions, because when we had all the referrals with COVID-19, we also had a lot of patients who'd had reactions to other vaccines who were worried about the COVID-19 vaccines. So we gave a lot of influenza vaccines and measles, mumps, rubella vaccines in the sort of tail of the COVID pandemic. But what you also have to remember is that the differential diagnosis, so the immunization stress-related responses, are actually much more common than anaphylaxis to vaccines. And it's important to be able to recognize and manage those properly so the patients are not labeled with an allergy or label themselves with an allergy that they don't have. So diagnose and reassure the patients. And with that, I thank my department and my group and the lab, and I thank you for your attention.